Every year, over 1 million people in the United States are admitted to an intensive care unit. These patients often experience prolonged periods of immobility due to the complexity of a critical illness, deep sedation, and perceived barriers to mobility. Early mobility is a term that describes activities related to mobilization, initiated immediately after stabilization of the patient's respiratory and hemodynamic status, within 24 to 48 hours after admission to the ICU. Early mobility may be indicated for patients who neurologically respond to verbal stimulation, as documented by their RASS, Richmond Agitation Sedation Scale score, are assessed to be within range of normal acceptable parameters of respiratory status, whose circulatory system is stable within the set criteria, or who have no injuries in which mobility is contraindicated. The decision to pursue early mobility hinges on the expert clinical judgment of the healthcare professional. Contraindications or limitations for early mobility would include compromised heart and respiratory rate, unstable blood pressure, brain injury resulting from stroke or trauma, and/or overall patient distress. To determine if the patient is a candidate for early mobility, you must assess the patient's neurological, respiratory, and circulatory status within 24 hours of admission and daily thereafter. If your patient does not meet the correct neurological, respiratory, or hemodynamic criteria, they are not ready for early mobility. Instead, continue to manually reposition the patient every 2 hours. Continue lateral rotation therapy for respiratory compromised or immobile patients if appropriate, and reassess every shift and as needed to determine patient readiness to initiate early mobility practices. To initiate early mobility when your patient shows signs of readiness, start each step with brief time intervals of 15 minutes and increase to 30 to 60 minutes each as patient tolerates. Progress to the next step when the patient demonstrates general criteria for advancement to the next step. Decrease time or go back a step if patient stability starts to deteriorate. The first step of bed early mobility is to raise the head of bed to 45 degrees to start adaptive positioning. As the head of bed is raising, note that InTouch's back smart pivot is engaging. This is the extra point of articulation in the bed that can help keep the patient supported and can help reduce downward migration of the patient in the bed. Step 2 of early mobility is to continue to keep the head of bed at 45 degrees and have the legs dependent. This is important because a flat lying position creates a shift of fluids away from the legs. Placing the legs in a dependent position will train the body to accommodate the shifting of the fluid back to the legs, helping prepare the patient for ambulation. Without this step, the patient may experience a drastic drop in blood pressure, causing them to become lightheaded or pass out. Step 3 is to continue with the full chair position. The chair button will automatically articulate into 3 degrees of Trendelenburg in this position, and head of bed will be raised to 65 degrees. Because of bed rest, ICU patients can experience trunk or core weakness, reducing their ability to support themselves in an upright position. So this is why the Trendelenburg-like articulation is needed. Because of muscle deconditioning, sitting in an upright position serves as muscle strengthening exercises, as well as hemodynamic and orthostatic training. In Step 4, the goal is to sit up at bedside and dangle with feet on the floor. Patients can then progress to standing at bedside. Step 5 is the final step where the patient will be aided to a standing position and then pivoted into a chair. This will engage all muscle groups and aid in systemic cardiovascular adjustments. This can assist in the patient's overall psychological status as well as their physiological status because of the body's response to movement against gravity and the patient's progression back toward his or her baseline. Studies over the years have shown that early mobility can in some cases lead to improvements in functional and cognitive outcomes. More ventilator-free days, significantly shorter duration of delirium and coma, and a decreased length of stay in the ICU. Stryker's InTouch ICU bed has features that may assist in early mobility exercises, such as a 16-inch low bed height, an independent knee gatch and foot drop, a one-touch cardiac chair position, as well as side rails that can support the technique of getting patients out of the side of the bed, allowing for transferable skills and the necessary nose-over-toes position. This algorithm is provided for the purpose of demonstrating how the InTouch bed may be used to assist with physical reconditioning and patient mobility. It is not a guarantee of warranty of product performance or patient outcomes. The decision to incorporate any components of this algorithm into clinical practices are the responsibility of your institution and its healthcare professionals. This algorithm is not a substitute for clinical judgment.